So good morning to you all. Topic for today's discussion is on host modulation. So to tell about host modulation, it is given in the 10th edition of Karanza in two chapters, chapter 16 and chapter 53. So those who are referring 10th edition, please do refer both the chapters to get the entire content of the topic. Okay. So initially, these are the contents which I'll be including in today's discussion. So we shall start with history. The concept of host modulation was put forward by two people. They are Williams and Golub in 1990. So that is Ray C. William and Lone Golub in 1990. So before explaining about host modulation, I want you to know about pathogenesis of periodontal disease. So initially, our thought about periodontal disease was that it was just a microorganism or microbial challenge leading to the signs and symptoms of disease progression. This was called as a linear bacterial model put forward in 1960. Later, we had another model called a Circa model in 1980, which states that it is not just a microbial challenge, but between the microbial challenge and signs and symptoms, we have something called as host immunoinflammatory response. So the response of the host against the microbial challenge is the one which is responsible for causing the signs and symptoms of periodontal disease. So after that, there is something called as a Conman's model, which is a non-linear model explaining the pathogens of periodontal disease, which is the most widely accepted model. This model explains the entire pathogenic process starting from microbial challenge. The microorganisms releases their antigens, their lipopolysaccharides, and their virulence factor, which acts on the host immunoinflammatory response. In turn, the host will produce their antibodies, their PMNs, against the microbes. At the same time, the host also releases certain inflammatory mediators like cytokines, prostaglandins, and MMP, that is matrix metalloproteinases, which will act on the connective tissue and alveolar bone, resulting in signs and symptoms of disease progression. So here we also have certain risk factors, that is environmental acquired risk factors and genetic risk factors, together constitute the disease progression. This was given by a person called as Conman, and hence the model is called as Conman's model, which explains the exact process in the pathogens of periodontal disease. So coming on to host modulation. You all know what a host is and what do you mean by modulation. So host modulation therapy is nothing but a treatment concept which aims to reduce the tissue destruction, stabilize or even regenerate the periodontium. How? By modifying or down-regulating the destructive aspects of the host and up-regulating the protective or regenerative responses. So what is a rationale or why do we do a host modulation therapy? It is nothing, it is basically we are doing the treatment for the host side of the host bacterial interaction. Okay. So HMT, it doesn't switch off the normal defense mechanism or inflammation. Instead, it will ameliorate means inhibit the excessive or pathologically elevated disease process and provide opportunities for wound healing and periodontal stability. So again, I'm explaining or showing the same model because our HMT are acting on these cytokines, prostaglandins and MMPs, which are the potential targets for host modulation therapy. So we all know what are cytokines. These are nothing but agents of inflammation which are released, basically categorized as pro-inflammatory and anti-inflammatory. Today our focus is on pro-inflammatory cytokines like interleukin 1, 6 and TNF alpha, that is human necrosis factor alpha, which are increased during inflammation. And prostaglandins are nothing, they are vasoactive fatty acid produced during the metabolism of arachidonic acid via cyclooxygenase or COX pathway. So studies have shown that these prostaglandins are elevated during inflammation. That is, they are produced by bacterial lipopolysaccharides and neutrophils, macrophages and fibroblasts, and they are elevated in periodontal disease process and compared to healthy individuals, and they are responsible for bone loss and periodontitis. So because of this understanding, it has led to the idea of host modulating agents which can act on these prostaglandins. So prostaglandins are of different types. So basically what we need to know is about prostaglandin E2 or PGE2, which are produced during the arachidonic acid metabolism. Next focus is on MMPs, that is matrix metalloproteinases. These are basically agents which are responsible for degrading our extracellular matrix component. Which is the extracellular matrix component? It is collagen. As we all know, collagen is a basic unit or basic protein present in all the periodontal tissue, starting from gingiva, periodontal ligament, cementum, and alveolar bone. and they are produced by a number of cells. So next, what is the classification? How do you classify these post-modulating agents? Basically, there are two types, locally administered and systemically administered. Systemically, we have NSAIDs, that is non-steroidal anti-inflammatory drugs, bisphosphonates, and sub-antimicrobial dose doxycycline. Among this, SDD and bisphosphonates are commonly asked as a short note in exam. Locally administered are again NSAIDs, which are topically administered. We have enamel matrix proteins, growth factors, and bone morphogenetic proteins. So this is the same picture which is shown in the model of pathogenesis. Here we are explaining onto each agent or which inflammatory mediator is being acted upon by which post-modulating agent. For example, I've told you NSAIDs, periostatus, doxycycline. So NSAIDs and doxycycline act on prostaglandins, and our periostat again, that is doxycycline, act on MMPs. As we all know, all the three agents are acting on the osteoclast, the cells responsible for bone resorption. Again, bisphosphonates will act directly on osteoclast, and doxycycline also act on osteoclast. So the same picture has to be explained in detail in the coming slides. So coming with the NSAIDs, we have told NSAIDs can be topically or systemically administered. This is a classification. Among this, aspirin is commonly used, or it was initially used as a post-modulating agent. Others like indomethacin, brufen, piroxicam, ketorolac. So this is already explained. NSAIDs are meant to act on prostaglandin because prostaglandins are inflammatory agents which are produced and responsible for bone loss and periodontal disease. But can we give NSAIDs for a long time? No. Studies have shown that NSAIDs when given for months or years as a host-modulating agent can cause serious possible side effects. One such effect is hemorrhage due to antiplatelet activity, that is profuse bleeding on long-term administration. Gastric ulceration, as we all know, diclofenac, which is an NSAID commonly used in pain relief. It can have an action on the gastric mucosa. It has a damaging effect on the cells of gastric mucosa, resulting in gastric ulceration, renal failure, and the most importantly, rebound effect. Rebound effect is nothing but sudden stoppage of NSAIDs when used as a host modulating agent. It can have a serious deleterious effect, that is, sudden stoppage can result in an abrupt increase in the bone loss, or bone loss can be accelerated if you stop NSAIDs all of a sudden, and this rate of bone loss will be much more than that was present initially before administration of the drug. This is called as rebound phenomenon. So because of all these side effects, NSAIDs are at present not used as a host modulating agent. The next agent is bisphosphonate. Bisphosphonate is nothing but a pyrophosphate group. It is called as a bone-seeking agent. Bone-seeking agent is it is meant for helping in bone formation by inhibiting the osteoclast, that is the cells responsible for bone resorption. Example for it is alendronate. Other than osteoclastic inhibition, this bisphosphonates also has anti-collagenase activity. As we have told previously, collagen is an important protein in the extracellular matrix responsible for maintenance of periodontal integrity. So anti-collagenase means inhibiting the action of collagenase enzyme, that is enzyme which damages the collagen. So in medicine, this bisphosphonates are having action, or it's given for treating osteoporosis, hypercalcemia, and other bone disorders like aging disease. Coming to what is the mechanism of action of bisphosphonates when given as a post-modulating agent. It has action on two levels, at the cellular and at the tissue level. Tissue level, it is reduction in the bone turnover by reducing or inhibiting bone resorption, decreasing the number of bone multicellular unit, thereby helping in maintaining net positive whole body bone balance. Cellular level, as we have mentioned previously, inhibit osteoclastic activity, that reduces osteoclastic recruitment, increases the apoptosis or death of osteoclastic cell, reduces the depth of resorption site, inhibits or reduces the release of inflammatory cytokines, and promotes or increases osteoblastic number or osteoblastic differentiation. These are some of the studies which have been done on humans in using bisphosphonates as an HMT, a post-modulating agent, as an adjunct to our mechanical therapy, that is scaling and root training, showing significant improvement in the periodontal parameters. Now, again, the same way as of NSAIDs, when we give this bisphosphonates for a long duration, what are the serious side effects? We have an important side effect called as BRONJ, that is bisphosphonate-related osteonecrosis of the jaw, also called as avascular bone necrosis. When bisphosphonates are given for a longer duration, it will not help in order to inhibit the healing of the jaw bones, resulting in a condition called as avascular necrosis. So that is why it cannot be given for a long term or long duration. Other side effects are inhibition of bone calcification and induces changes in the WBCs. Because of these side effects, they are no longer drugs in the treatment of periodontal disease. The next, the first FDA or ADA approved post-modulating agent is SDD. It is called as sub-antimicrobial dose doxycycline. That is doxycycline when given at a dosage below its antimicrobial dose. We all know that 100 mg is the antimicrobial dose of doxycycline given for periodontal purpose. So below that dosage, that is less than 100, normally 20 mg is given twice daily for 3 months. Can be given up to 9 months in post-modulation purpose. Now, why do we select doxycycline? Why not any other antibiotics? Doxycycline has an ability to be concentrated in the gingival clavicular fluid about 5 to 10 times more than that in the blood. And also it has an ability called a substantivity, that is, there will be a constant or continuous release of the active ingredient over a long duration, even after the some time of the drug has been given. So because of the substantivity and the ability to be concentrated in the GCF, doxycycline has been selected as a post-modulating agent. Studies have shown that when given as an adjunct along with scaling and root training, it can inhibit the MMPs. MMPs are previously mentioned, and the cells will secrete MMPs. Now, what is the mechanism of action? This is a picture taken from Carranza 10th edition showing the exact mechanism of action of doxycycline at 3 levels, at the epithelial level, at the connective tissue level, and at the level of alveolar bone. So as we have said, the basic mechanism is to inhibit MMP, that is matrix metalloproteinases, which are responsible for degradation or damage to the collagen. It's a component of extracellular matrix. So at the epithelial level, it can inhibit production of epithelial-derived MMPs. Similarly, at the connective tissue level, it inhibits the active MMPs, inhibit oxidative activation of MMPs, down-regulates the inflammatory cytokines, scavenges and inhibits reactive oxygen species, which are the agents produced during the extracellular killing mechanism by the neutrophils. Also stimulates production of fibroblast-derived collagen. Now, at the alveolar bone level, inhibits osteoclastic activity and bone resorption, promotes the osteoblastic activity and bone formation. Periostat is the commercial available doxycycline. It is called as Periostat, which is available commercially. 20 milligrams twice daily for 3 months, extending up to 9 months. Never use SDD as a monotherapy. It is used as an adjunct to scaling and root training procedures. Now coming to the locally administered. Locally administered, as we have said, again we have NSAIDs like ketorolac or ketoprofen, which can be given topically as a mouthwash. Studies have shown significant increase in the GCF concentration of ketorolac, and it can inhibit bone loss in periodontitis patient. Others are enamel matrix protein, which can stimulate regeneration of the periodontium, that is bone, periodontal ligament cementum, commercially available as endogain. Growth factors like platelet-derived growth factor, insulin-like growth factor, bone morphogenetic proteins, then recombinant form of platelet-derived growth factor and recombinant form of BMPs, which is available as GEM21S and Infuse. These are the currently FDA approved, that is endogain, GEM21 and Infuse, which is used in bone regeneration. And we have some newer newer HMPs which has been commercially available, one of which is CMT, it is chemically modified tetracycline. Tetracycline without any antibiotic property but having anti-collagenase or anti-collagenollytic effect, that is CMT, CMT3 and CMT8, which is used as a post-modulating agent. Then others recently available are anti-cytokine drugs, TNF-alpha antagonist, interleukin receptor antagonist, etc. Coming to conclusion, So as we are now aware of the exact pathogenesis of periodontal disease and the role of post-immunoinflammatory response in the progression of periodontal disease, our approach to treat the host site by giving post-modulating agent have seen fruitful result in treating the periodontal disease. Thank you.